يعني. اوكي. I'm not sure what no. Anyway, the first lecture is going to be by introducing.
المشاركين اللي هم دول هيبقوا مشاركين معانا على طول من الأول أثناء المحاضرة كمان؟
من الأول أهوت، من الأول دلوقتي.
تمام.
and the other attendees, they can vote in the chat. They can say option 1, option 2, option 3 on the chat, or differential diagnosis, or whatever you are requesting for that, Prof. Mu'taz.
Thank you.
We are live on Facebook now, and we are going to start in actually in few seconds.
Dr. Tahan is with us.
Yes, he is. Yeah, he's muted. Yeah.
Yes. How are you?
اوكي ازي حضرتك دكتور طحان؟
أهلا بحضرتك. أهلا بك.
I'm so pleased today to start the third module, which is a little bit much more specialized than the other modules. And we're starting today. It is an honor to start the pediatric anesthesia tonight in the presence of 3 eminent speakers and 2 eminent and top moderator. We'll start with the microphone is going to Prof. Samir Ansari. The first time since we started this course on Sunday, not to be a lecture, but he's honoring us today by his presence to be a moderator of this session with Professor Manal Gohari. Prof. Samir, all for you. Thank you.
Thank you, Professor. Good evening. Good evening, my dear colleagues. Good evening, my dear attendees. Really, today we are going to enjoy a pediatric night. Especially, we have 3 professional stars in pediatric anesthesia sharing us their experience in 3 hot topics in that field. And as you know, this field is unique in its it is a critical branch which need special attention and special experience and special talent because of its unique physiology, unique characters, you need a unique special physiology, anatomy, and even in drug doses. We have to be oriented with its pharmacokinetic, pharmacodynamics, which differ largely from that used in adult. Pediatric anesthesia, as we know, carry special risk in morbidity and mortality more than, of course, the adult anesthesia. Today, really, I am going to be a moderator, and actually, I like to present, and I like presentations, and even I like to attend the presentation. But also, I like to be a moderator, especially if I am going to introduce such famous and professional speakers and guest speaker. Like today, we have actually 3, as I said, 3 famous stars specialized in pediatric anesthesia, sharing us their long and extended experience in pediatric anesthesia. And please, my dear attendees, please help me now to welcome and introduce the prestigious and talent and professional, and also my dear colleague, Professor Dr. Hani El-Dahabi, Chairman of Anesthesia and Intensive Care and Pain Management department at our dear and lovely university, Ain Shams Hospitals. Welcome, my dear colleague, Professor Dr. Hani. Mike with you now.
Thank you, Dr. Samir. It's my honor to be with you and my honor to hear these nice words about me. Thanks, Dr. Saad Mahdi, for letting me in this marvelous course, which is growing day by day. I'll start my talk today about basics of neonatal anesthesia, and I'll take the words of Dr. Ansari, who said that the great physiological and pharmacological differences or changes are there for these young patients, and they need continuous knowledge, continuous practice and skills added to an adequate monitoring and equipments to have a good outcome. We all know that the neonates are, we call them from day 0 to 29, whether full term when they reach 37 weeks, or preterm when they are less than that, and the post-conceptual age is the gestational age add to it the chronological age. Anesthetic considerations usually comes from being neonate, and most of it comes from being neonates. We call it age-specific considerations, and of course the type of surgery. If we take system by system and see what happened in it and how does it affect our practice, we start with the CNS, and today we all know that neonates in pain, and most of the pain components are there by 30 weeks of gestation, starting from the peripheral receptors down to the spinal cords, ascending tract, and cerebral modulation. However, the descending pathway is not complete. Neurotransmitters are not there before 48 weeks of gestation. What does it mean that the descending pathway, the inhibitory pathway that modulates pain, that will result in greater intensity of pain for a longer time, hyperinnervation of the areas next to the injured tissues, secondary hyperalgesia, and of course a 30%, at least 30% reduction in pain threshold with the next noxious stimulation. All these would have short-term consequences and long-term consequences on the nervous system of the neonate. They also have fragile cerebral blood vessels, which render them liable or prone for intraventricular hemorrhage in case of stress. Their spinal cord definitely extends at a lower level, and it's easy to get with that when doing a caudal epidural. We come to it later in this talk. And of course, the volume of CSF per kg is higher, and the spinal surface area are larger in units. That means that when doing spinal anesthesia, we need more doses of local anesthetics. When it comes to the respiratory system, we all know that they have higher oxygen consumption, higher respiratory rate, the minute ventilation is higher. But when they are apneic, with this high oxygen consumption, so desaturation occurs more rapidly. Their lung compliance is less, and while their chest compliance is high. So by the end of apnea, they tend to get atelectasis. So whenever you intubate a neonate, the first thing is to recruit this segmental atelectasis that happens during apnea. Their diaphragm gets easily fatigued, and they cannot increase their work. So again, they get easily fatigued. Their breathing, which is we call it periodic breathing, normal periodic breathing of the neonate, is accentuated by the anesthetics, opioids, and make them render for post-operative apnea. We all know that the breathing circuit that most frequently used is the modified ISTPs. So let's see what will happen with this respiratory feature. We use the modified ISTPs because it's light, it's low resistance, no valves in it, the space is low, compression volume is low, gases goes in and out fast, compliance, the compliance of the circuit is low, and of course we can feel the compliance of the lungs and chest wall. However, we cannot add, most of the gases are dry, very low humidity, and it needs a learning curve to properly use it to the desired volume and pressure. And of course, it's difficult to scavenge. The bag may get obstructed and unnoticed. So This is the other type of circuit that we use when controlling ventilation, which is a circuit system. Well, this is a 15 millimeter diameter. When using these two circuits, we have to keep in mind two concepts: the headspace concept, which of the circuit, for example, and the resistance of the circuit, which comes from hoses, valves, and filters. If the unit breathes spontaneously in this circuit, the dead space may approach the tidal volume of the unit. You can imagine if we add to the spontaneous breathing one of these with a dead space of 34 up to 50 mils. So you cannot leave a unit breathing spontaneously in this circuit. And as a general rule, as we will see, that we cannot leave the unit breathing spontaneously for a long time because they get exhausted, especially when they are intubated and with a tube with high resistance, a lot of work breathing. We cannot, if we add a filter to a spontaneous breathing, this is completely wrong. And even if they breathe spontaneously with through a laryngeal mask, although the resistance is low, but the dead space is high. Anatomically, they have a large box. Of course, this is not an unit. This is a large box. We have large box which keep the head flexed forwards over the neck. So when you intubate them, you need a shoulder roll. You need this is the headrest and shoulder roll. That tries to align this trachea to the sternal end. Nasal turbinates are not there, so they breathe easily through the nose, and they suffer a lot when nasal obstruction. The floor of the mouth is compressible, so frequently if you press on the floor of the mouth from outside, then the obstruction of the oral airway occurs. The tongue is large and will again easily obstruct oral airway. And of course, we know that the larynx is high, and you have difficulty in aligning the visual axis of the three axes that we know. That's why in most of the case, we need external laryngeal manipulation to get a good view. The epiglottis is shaped, thin, and you cannot easily take it up, lift it up with the straight blades, which is commonly used in units. The vocal cords are slightly angled anteriorly, so most of the tubes come and hit the anterior wall of the larynx. So you need to tilt the tube to the left or decrease make a little bit of flex. Most of the you have to examine the lateral view of the mandible to see if there is micrognathia is there, which is a very important and common indicator of difficult intubation of the trachea. Signs of airway obstructions. We all know that it includes a stridor, prolonged inspiration, some voice changes, crying is changes, rocking movement of the chest, abdomen, and of course, when they use accessory muscles, you get tracheal tug, flaring nostril, and retraction of the intercostals. They tend to get postoperative apnea in up to 44 weeks in term units and up to 60 weeks in preterm units. And the central and the apnea is commonly a mixed apnea, both central and obstructive type. Postoperative apnea is exacerbated by many factors, but we have anemia is the most important factor that predisposes to postoperative apnea. Other factors include hypothermia, hypoglycemia, hypoxemia, narcotics, and we treat it by raising the hematocrit, increasing oxygen, giving caffeine maybe not so, but when we give this, we don't send them home, and as they are safe, we keep on monitoring them for at least 12 hours of apnea-free period. When we come to the cardiovascular consideration related to the age, of course, they have high cardiac output, which is mainly dependent on heart rate. Their fetal hemoglobin has high affinity for oxygen. Their contractility is dependent on extracellular calcium. This is very important because if calcium is low, then it's difficult to get normal blood pressure. Hypovolemia, or they have a predominant parasympathetic tone, so they don't get much tachycardia when they are light anesthesia, under light anesthesia or hypovolemic. Frequently, period do not close if there is hypercarbia or hypoxia after birth, and which gives high pressure in the pulmonary artery, making a right to left shunt from the pulmonary artery to the aorta. When the pulmonary vascular resistance goes down later on, then, and this is not closed, then the flow will be reversed. In patients with patent ductus arteriosus, using the right arm saturation is recommended. They lose heat by 4 ways. The most important is by radiation, which accounts to about 60%. Second is by convection. Okay, so it is important to keep the room temperature high, to wrap, to do cotton wraps around the limbs, and of course keeping air warming mattress, which is the most effective air warming way in OR. The renal function, we have less glomerular filtration rate. We cannot retain sodium from being excreted in urine, and of course, when giving drugs, they have a large extracellular fluid, and together with decreased renal excretion. So the initial dose may be increased for many drugs, and but the intervals are usually longer. Their fluid requirements goes up through the first 5 days to be 115 mg, and the electrolytes here. This is very important because frequently at the beginning of practicing pediatric anesthesia, many patients were cancelled for having potassium level of 6, and residents, junior residents, would think that this is high and needs some correction, but this is normal ratio for potassium. They also have higher levels of calcium, especially in the first day, and this is in day 28. So at 6.2 or 6.3, we go to surgery without any problem. Of course, we may consider not giving succinate choline. When it comes to glucose homeostasis, we know the default is that all neonates need glucose infusion per kg per minute, about 5 to 8 milligrams per kg per minute. Their egoglycemic range is a range between 50 to 90. That means 40 should be treated, 110 should reduce the infusion rate of glucose. Of course, the lower limit is higher if the mother is diabetic and the neonate is the first 2 or 3 days. Hypoglycemia is common for if we are critically ill, if they fast for a long time. If you suddenly stop the TPM coming from the NICU. We have to know that most of the signs of hypoglycemia are blunted and non-specific, and we have to measure regularly the random blood sugar during operation. Is it then justified to use only glucose solution during operations? Of course not. We need to give the maintenance of glucose or half the maintenance of glucose because of stress, and then give the rest of the fluid as balanced salt solutions. We commonly have reflux, we commonly have pernicious. The hepatic drug metabolism is maybe especially when their intra-abdominal pressure is high. The lowest acceptable hematocrit is higher than those of adults. If you accept like 25 or 30 in adults, the lowest acceptable hematocrit is 35. Their coagulation profile is almost nothing peculiar in it. So the fasting situation, we all know that breast milk, 3 to 4 hours, we stop it. We keep giving clear fluids now up to 1 hour, and probably Dr. Mumtaz will say up to 0 hours. If they have clear fluid, they tell you they have clear fluid now, then by the time they come, you just can induce anesthesia. In case of emergency and in case of full stomach, then you need to decompress the stomach in different positions. So you fix your needle with the tube, try to do gentle aspiration, supine, and then to the right side, turn to the right side, turn to the left side, and repeat the aspiration. Pre-medication is debatable. Atropine is maybe given. The lowest dose is 100 mics. Whatever the body weight of the neonate. Some people do not prefer to give. Of course, if there is pain, so the best pre-medication is morphine. Standard monitoring are added. ECG, stethoscope or pericardial stethoscope, blood pressure, temperature probes, whether lower esophageal or nasopharyngeal or rectal. Pulse oximeter definitely, but I have to elaborate that if you have a hypoxic unit, do not keep looking at the oxygen saturation, because the pulse oximeter takes about 10 seconds to average the reading. So you have to look at the chest expansion. End-tidal carbon side is crucial, definitely, but sometimes you get difficulty in getting good tracing of the end-tidal carbon dioxide, especially if you have a small endotracheal tube with continuous leak around it. If the leak is large, then you will get that. This is definitely less than the actual end-tidal carbon dioxide. If you appeal to this, then it will go down even more. So this is a point where you measure end-tidal carbon dioxide. If you have this shape, then probably it's less than the real life. How long we pre-oxygenate neonates? That's since 1998. They said 60 seconds or 1 minute of 6 liters is enough to give you about like more than 1 minute of before they desaturate. Some people would prefer to get the end-tidal oxygen concentration above 80%, but believe me, it's difficult to achieve what you want. It's difficult to do real pre-oxygenation in units, and most of the time you need to do gentle manual ventilation to units before you intubate them, because otherwise you will get you try to intubate very early with the risk of regurgitation. Most of us will go for inhalation induction, because even if I have a needle, if I have an IV in place, because they gradually get loose their airway, there is no pain from propofol. Definitely, if you have a short procedure, then they will better than IV induction, and maybe the parental presence during induction will help in that. If you have IV access and they are hemodynamically stable, then you may go for propofol, or if they are unstable, you may go for ketamine. If there is no IV access or the airway is compromised and you want to go for single inhalation, it's fine, 6%. By the end of when they are deep, when there's breathing slows and there's end-tidal carbon dioxide starts to increase, that means they are in deep level now for intubation. Very common now to give a hybrid technique at this stage and give 40 milligrams per kg. Gives you apnea for intubation, but they cough it. Can we do a rapid sequence induction in units? But less classic rapid sequence induction that is in our mind for adults is not suitable for units, because they easily get these hypoxic during the during apnea, and while they are not really deep enough. So again, you may get start early intubation, and which may predispose to regurgitation. So actually, there is no cricoid pressure in real life. You can do it because you will disturb everything. You cannot put your 2 fingers exactly on the cricoid pressure. Again, neonates must be gently, must be ventilated between induction and intubation. The gold standard is to intubate neonates, whether for long procedure, intermediate time, or even for short procedure. Some would allow them for a very short, brief cases like circumcision to have a face mask with assisted breathing or a laryngeal mask in place. But remember that size 1 is commonly misplaced. And you frequently, if you keep on manually ventilating them, you may inflate the stomach. Succinylcholine, although the black box warning on the label is in the box itself, but if you need succinylcholine, if it is indicated for example, difficult intubation case, then you can give it without hesitation. Non-depolarizer is same dose as in adults, but we frequently give a single dose, like operation which stays for an hour, and we give the intubating dose, then probably we will not give another dose of non-suppressant. Endotracheal intubation, gold standard, oral or nasal. Nasal if we are going to put the patient on prone position or even lateral position, or if we have a limited head access like in maxillofacial, then a nasal intubation may be a solution. The leak pressure should be less than 25, and in most of the case we intubate with non-profit tubes because first of all it puts less pressure on the mucosa. You can put a larger tube, one size larger, but if you have poor lung compliance, then you may put a cuff tube. Frequently, we put the microcuff tube if you have it. If you don't have, then the other, the regular one will be okay, but you have to measure the cuff pressure and make sure that it's not tightly inflated. Gold standard again, after intubation, as we said, the atelectasis, commonly, segmental atelectasis commonly occur. So we need to recruit the lungs after intubation, immediately after intubation, and then to put them in feet that will prevent more atelectasis. This is a paraglostic technique which you go from the far right side. So you don't you go directly to the base, to the right side of the base of the tongue, directly to the epiglottis. Just take it with you, and you can intubate in this position. Here is these 2 types. This is a microcuff tube, which they replaced the Murphy eye with this, so that the tube, the cuff is more distal. That is more anatomical because here is the narrowest part, probably is here, which may give, when using this microcuff tube, then probably post-intubation group would be less. But the size should be, is frequently be one size less than if you are going to put 3.5 non-cuff, then with the microcuff, then you put size 3. Pressure volume control or manual, which is frequently used, definitely if you want to use a circle system with them on controlled ventilation, then classic teaching is the pressure control is the first choice because it avoids the barotrauma and compensates for leaks. What happened is that we go for the PIP, the peak inspirated pressure. We set the highest pressure that we want. For example, starting by 10 or 12. And check what is the expired volume. How this pressure with the current compliance of the chest wall and the lung and the surface, everything will give an expired, because if you are giving pressure control, you have to look for the volume. If you are if you are giving volume control, you have to look for the pressure. Then after checking this target, our tidal volume, usually we go for a protective lung strategy. The upper limit is like 6 mL. I personally go for 6 to start with, and then so I increase the pressure until I get 6 mL per kg. And then after that, I go up, I manipulate the respiratory rate to the desired in the tidal carbon dioxide and add it. What factors that affect the tidal volume in pressure control? The compliance, and here we have to bear in mind that the hand surgeon, the surgeon's hand itself, will decrease the compliance, and if the assistant retracts vigorously, then you will probably get nothing, no tidal volume. So you have to keep watching the expired tidal volume yourself, or use a pressure control volume guaranteed. This is a very useful. The other two factors are the inspiratory pressure, which if you increase it, then you get more tidal volume, and the inspiratory time difference. What is the disadvantage of pressure control is if the tube is kinky, for example, it will not allow. Disadvantage of volume control that we occasionally may use in case of decreased lung compliance or anaesthesiology or whatever. Then, because the disadvantage is that they do not compensate for leaks. And the phase flow, if you increase the phase flow, then the tidal volume increase goes up. If you decrease it, it will decrease. And of course, you lose volume through the circuit compliance. So if you adjust for example, if you put 15 mils, then you may lose 20 of them in the circuit. Of course, maintenance, I don't see anybody is using Halothane now. Occasionally, in some cases of difficult intubation, I still use Halothane for more time of laryngoscopy. Narcotics for fentanyl or morphine. The difference is, although morphine has longer duration that stay for like 8 or 9 hours, but the half-life of fentanyl is variable, extremely variable. It may be half an hour, maybe 7 or 8 hours. Then it depends on the high intra-abdominal pressure. So we usually avoid short procedures, and we revert to a regional block. The narcotics, again, they have low rate of clearance, high volume distribution, prolonged half-life. Their plasma concentration after bolus dose of narcotics is high. We can give narcotics easily to a patient who will be ventilated in the ICU, but we tend to stay away if we are planning to extubate and recover the patient. When it comes to regional blocks, the CSF volume per kg are higher. You see here it's almost 15 ml per kg. It's like 1.5 ml in adults. So this means that they, together with a leak around the spinal nerve, we have to give higher doses of glucoacids for spinal in minutes. Their turnover, CSF turnover rates are high, so the spinal will stay half an hour, 40 minutes maximum, unless you add it enough. Their globular fat is less dense, and you can easily spread a catheter caudally up to higher levels. So traditionally, we give spinal doses. You ask assistant to hold the neonate for you in a sitting position and use a separate needle. You just break the skin and by a separate needle to avoid inclusion dermoid, and then we give 0.1 ml per kg of bupivacaine 0.5% with an insulin syringe. this is higher dose than in others. High spinal levels are not presented with hypotension. It's usually apnea and desaturation. Epidural doses here where we reduce the dose of local anesthetic. So instead of giving the ceiling, our ceiling of order anesthesia, instead of 1 milli per kg bupropion for older children, we make it like 0.7 milli per kg once of 0.25%. Volume replacement is important because hemorrhage and blood loss and it accounts for like 9% of cardiac arrest in OR. So it is very important to know or to diagnose, to assess the hydration state. Here, this one is always, when I ask what are the signs of dehydration, they go for sunken eyes, depressed fontanelle. This is extremely severe form of dehydration. But mild dehydration, which is common, you get only urine output less than usual. You need to weigh the swabs before it dries, and most of the intraoperative blood loss is replaced by balanced salt solution. And of course, this is the equation for maximal allowable blood loss. Emergence, I tend to reverse all muscle relaxants whatever the time given since the last dose, and I depend on two main features: moving all limbs and giving facial grimacing. This is ensure awake intubation. So when you take the patient from deep stage through the light stage into the awake stage, and do not extubate into the light and the stage of light anesthesia, you probably are getting less complications to extubate awake. And the plan usually is usually planned preoperatively with a regional block infiltration, paracetamol. If his patient is going to ICU, then we can give morphine. We'll go through how many minutes? I think still maybe 5 minutes more. Okay. We get some cases. This is encephalocele, for example. Encephalocele has problems of that they tend to get when repair these meninges, they get a shunt. So usually they fix a shunt first, and during intubation we try to avoid damage to this one, blood loss, hypothermia, and even latex allergy is common. Second case is tracheostomy fistula. Just a concept that I want to elaborate. This is a common type. Okay, so the fistula is low. It's just above the cranium, maybe a centimeter above the cranium. So your aim is not to ventilate through the fistula, because if your tube is high, then you probably will get intubated. You inflate the stomach, and your surgeon will ask the surgeon to change their decision and go for gastrostomy during operation. This is a case that will indicate, for me, will indicate a spinal anesthesia, which is a unit staying for long in ICU. And after passing through ventilation and intraventricular hemorrhage, multiple bronchopulmonary dysplasia, multiple medications, now their parents are looking for an inguinal and hernia repair. And this is, for me, an indication for sole spinal anesthesia without sedation, because if you give sedation, then you can still get apnea. I will share very short 2 videos for the last case. In a second, I will do it. No. Okay. This is This is neonate with, you can see, huge, rapidly growing mass that is here in the frontal, coming from the frontal bone, and another mass on the right side of the neck. Okay. This I'll share the video of intubation. That's the final video. Okay, I'll leave you with this video. Actually, that's a nightmare for me, for myself. And here I'm putting some xylophane gel on the right paraglossal area with my little finger, and then now I went with my little finger melting the epiglottis and the upper part of the larynx with a calculated 2p size lidocaine gel, which probably gives 10 together give 10 milligrams of lidocaine, and then using the CMAC, pediatric CMAC for intubation. This is real time, no editing. Sorry, because the screen is tilted, but yeah, I anesthetized the right paraglossal base of the tongue, and then with my finger, as I said, I went to the epiglottis, making its upper and lower surface, and then we give another half cc of 2% lidocaine that I will spray. Here you go. This is the lidocaine 2%. Of course, there are other ways of doing this. I mean, by inducing inhalation anesthesia, nasopharyngeal way, but I mean, this is a safe option for me, and I successfully intubated that patient. And this here the patient is intubated and surgery, and this we did the first part of surgery. And thank you very much. Thank you.
Thank you, Dr. Hani. Really attractive and amazing lectures, highly beneficial for anyone who wants or interested to work in pediatric anesthesia. We have some questions here, Dr. Hani. The first one from Carlos Munir. He asked about, is propofol used before 1 year? Is propofol?
Yeah, the answer, the answer, it's a common question, and the answer is off-label use is extremely common, using propofol during even infancy and neonatal.
Second question is from Munis Abu Zdera. Do you have a reference for no cricoid pressure? If you have reference, please, you can write for him. The other questions from Muhammad Hashnam. Yes?
I cannot hear the question. I didn't follow the question. Can you say the question again, please?
Do you have a reference for no cricoid pressure?
For no cricoid pressure?
For no
well,
pressure.
It's there is no cricoid pressure in units. If people try to do cricoid pressure and then frequently they get distorted anatomy, and then they just ask the assistant to leave the cravat, to let it out and intubate the patient.
He interested
Because
he interested just to
Yeah.
know the reference, Dr. Ali. He wants the reference.
I can
If you
send
yes,
send
you
it
can send.
on this. Yes.
Third question is from Muhammad Hashim for induction. What you prefer for induction for pediatric?
Okay. It depends on many factors. First, how familiar you are in doing, for example, inhalation, induction and intubation. I frequently do use inhalation induction because most of the pediatric procedures are relatively short, and I need to exhibit them at the end. Of course, you can exhibit them when giving propofol, but it takes, the recovery time is long. I give inhalation anesthesia, sevoflurane, and if I can ventilate the neonate easily, then I give a dose of muscle relaxant, which make life easy for me. I just ventilate. It works. The onset is very fast. If you give even a trachurium, in 20 seconds, it works. You can intubate the patient. So my preference is that inhalation induction, easy ventilation, and muscle relaxant, and external laryngeal manipulation. The concept, why? Because the nightmare of anesthesiologists is to have an inhalation induction and a trial of intubation early, which is difficult, and then the patient goes into spasm and they cannot intubate and they desaturate, and this is the worst scenario. So I consider giving muscle relaxant and ventilating the neonate as de-arming the patient. Of course, if you give propofol after sevoflurane, you may get closer results, but I'm not fond of it.
Other questions from Muhammad Muqbil. Fentanyl can be used in small doses?
Yes, yes, definitely. For even, I mean, 1 to 2 mics per kg is enough, but you have to watch the recovery of, or the signs of that the fentanyl is wearing off. Because if you give on time, on basis of time, you may every half an hour you give fentanyl, then probably you will have longer time for extubation at the end of surgery.
From Muhammad Muqbil, also intraoperative pain management. Intraoperative pain management. I think
yes.
You need direction.
A lot of, yeah, it's a long one, but the concept is we give light general anesthesia combined with a regional block. This is the best if you can give both. For example, lower abdominal surgery, even up to umbilical hernia in infants. Single shot of epidural will help you to do that. If that's very common. Local infiltration of wounds for thoracotomy, for example, you can thread a catheter through the epidural space and measure the how many centimeters to the dermatome of the incision. Leave it there with no X-ray, nothing. No, you just assume it's in place and start giving epidural. But the patient should go to an NICU after that.
From Jumana Baj, she asked about is it safe to use Stogamedics in infant? Is it safe?
I have no experience using it. I have no experience in using it. I use the Hoffman degradation products of non-depolarizer muscle relaxant. Maybe my colleagues, Dr. Martez, may comment on this.
Again, Dr. Hani, what was that again? Yeah.
Do you have experience in using Stogamedex and
Stogamedex in infant?
Oh yeah. We do use it, obviously, particularly in difficult intubation, but not generally. No?
Please.
4 milligram per kilo to reverse, but mainly in emergency. not as. Hello.
Yes, with you. Hearing you, Dr. Mu'taz.
Yeah, that's fine.
Not in routine use.
Some colleagues, I know some colleagues use it in routine use, but
Okay.
generally it's a very minority. And in our hospital, we don't use it in routine use, in routine reversal. We only use it in emergency. Yeah, emergency, i.e., you've used trocaronium and then you've got a difficult intubation. You won't wake the child up, so you give it as in the emergency situations.
Yes.
There's some, yeah.
So long you have a good experience in Sogamedics, Dr. Mu'taz.
I'm sorry, any more questions?
I wanted to ask you if there is any recolorization after using Sogamedics.
I must say, in children, we don't use it a lot. We don't have a huge experience in Sigidemics in children and infants.
Yeah.
In adults, we've not seen recolorization, but in children, we don't have that experience to be able to comment on that.
Okay, thank you.
Yeah, what is?
From Jumana, Dr. Hani also, she asked about, is it recommended to use C-max laryngoscopy instead of gyroscope? You hear me, Dr. Hani? Dr. Hani?
For some reason, Dr. Hani disappeared. If you don't mind, Prof, we can start now the second lecture because the time is running very fast, you know.
هشام تعالى شغل لي الكاميرا.
Prof. Dr. Manal, I think.
Okay, okay, I am with you. Let me show the camera, please, Dr. Saad.
Yeah, you go ahead.
Okay, yeah. I'm here. Okay.
Thank you.
Good evening, professors and colleagues. First of all, I would like to thank Dr. Saad and the Mega Online Academy for giving me this privilege to be part of this session. The next presentation, titled Pediatric Emergencies, will be lectured by Professor Mu'taz Abdurrahman, Consultant Anesthetist, Royal Manchester Children's Hospital, Manchester University Hospital Trust. Professor Mu'taz Abdurrahman is an eminent anesthetist, not only in Egypt, but worldwide. It's a great chance for me to introduce Dr. Mu'taz and be a moderator for this session. اتفضل دكتور معتز.
Thank you very much, Dr. Manal, for the introduction. And I would like to acknowledge and thank very much Professor Saad and the team he's working with for allowing us to actually get into this course, and for the effort which has been done. I could see all the lectures and all the speakers. It's a huge effort, and I would say I've not seen anything like that, which is carrying on continuously, and I hope that stays and we can keep it up. Today we're going to talk about the emergencies in pediatric anesthesia, and to tackle this subject, I thought it's a really very difficult one, because what sort of emergency we would like to talk about? Would we like to talk about emergencies as in an APLS type scenario, advanced pediatric life support type scenario outside the OR, or would we like to talk about emergencies under pediatric anesthesia during anesthesia or peri-anesthetic emergencies? So, and I tried actually to combine everything to give the audience as much information we can during this 40 minutes or half an hour. So if you talk about the emergencies, you need to specify what type of emergencies, and it comes down to either a seriously ill child or a seriously injured child. And that's the classification, the classic classification for or from the APLS. The most important thing is that an anesthetist or one who actually deals with emergencies need to have a structural approach. And then again, the classic approach for dealing with emergencies through the APLS would be a primary survey and a secondary survey. The primary, and then the primary survey we're going to go through, which is always to do with ABC, the famous ABC. I just put this slide to just give people a quick reminder about cardiac arrest in children. It's not essentially due to cardiac disease. So if it happens under anesthesia, there must be something happening, primarily hypoxia and hypoxemia, which causes to this. It does have a poor outcome unless it actually happened under anesthesia or perioperatively, where he corrected the cause very quickly. So if you talk about cardiac arrest in general, when we say poor outcome, this is out of hospital cardiac arrest. In hospital cardiac arrest, and indeed in the OR cardiac arrest, and particularly if it was due to a cause in relation to anesthesia, you need to have a full hope that you're going to get this child back again. It's not like the out of hospital cardiac arrest where the outcome is very poor. In such circumstances, if you've got a cause and you try to correct it, you probably in most cases will get by. Needless to say that most cardiac arrests in children are due to asystole or pulseless electric activity, which means dehydration, hypovolemia, and such, and hypoxemia. Again, the structured approach, which is adopted by the APLS in managing such cases, and I actually like it because at least if you have a framework in the back of your mind that you're actually talking about early assessment, immediate treatment, which is resuscitation, whether you are in the operating theatre or whether you are in A&E, on a ward, outside hospital, just remember that you got to do an assessment, a quick assessment, resuscitation, which means immediate treatment, and then follow-up assessment. This is the secondary survey, and emergency treatment specific to the actual reason or cause of the illness. And then later on, when the patient is fine, late assessment and initiative definitive treatment if the reason is something to do with trauma or something to do with an infection or something like that. Later on, the medics or the surgeons can deal with this. And obviously, you need to transfer the child to the appropriate clinical area if this was not in the emergency theatre or in the operating theatre. The classic APLS approach is ABCD: airway, breathing, circulation, disability, and exposure. Disability is basically neurology. You need to know how this patient is looking like from a neurology point of view, and exposure, so that we do not actually miss the rash and the fever. You need to look at the skin, whether you are in theatre, operating theatre, or actually outside. Don't miss the skin because it gives you valuable information, and including fever as well. I think we talked about this: primary assessment, resuscitation, secondary assessment, emergency, diagnosis, and definitive management. This would be in the back of your head. The common scenarios or the common themes we do have, again, for all children, regardless where that is, it's either airway and breathing. And it's very important for the clinician, particularly I understand that there are quite a lot of trainees attending this session. It's of paramount importance that the clinician, particularly the anesthetist, is very well skilled in the recognition of the potential respiratory failure or respiratory problem. And it comes down to either effort in breathing or efficacy of breathing. And you need to be able to suss out the stridor, look at the respiratory rate, and if it's quite high, that means pneumonia, recession, grunting, accessory muscle use, flaring of nostrils, and gasping. These are all signs of difficulty and labored breathing, which denotes you're dealing with a respiratory problem here. The efficacy of breathing, obviously, if you look at the chest expansion and the abdominal exertion, and it's actually deficient, and if you put your stethoscope on the chest and it's silent, then again, this is quite an eminent sign of respiratory failure, and obviously oxygen saturation. Quickly again, the circulation, you've got the heart rate, the pulse, the capillary fill, the blood pressure, and I'm not going to dwell a lot into this, but remember in children, we're talking about a heart rate between 70 and 220, less than 70, you're talking about a failed pump here, because they depend on the heart rate more than anything else, and you need to start resuscitation if it goes 60 or below. Bradycardia 60 or below, and particularly infant and young children, and you need to start your resuscitation. You don't wait until you get a full cardiac arrest. We're not going to teach people how to actually gauge the pulse volume, but it's very important. One of the most important signs in children is the capillary fill time. And what you do is you press for 5 seconds on the sternum or on a digit, sometimes on the forehead, and some people do it that way. And then after the 5 seconds, you remove your finger, and the return of circulation should come back after 2 seconds. And it's a good sign of decent cardiac output if it's 2 seconds or less. Blood pressure, you need to remember that blood pressure, even in adults, is a late sign of shock. Children do have a very good way of actually maintaining their blood pressure till the end. Neurological assessment, the famous AVPU, if the child is alert, responsive to voice. The Glasgow Coma score scale here is probably needs to be modified, and we go by the AVPU. So alert, respond to voice, responding only to pain is kind of a later sign of neurology, and non-responsive to all stimuli. Responds only to pain and unresponsive, that means you're heading for intubation and full resuscitation. You have to look at the pupil size, reaction, and dilatation and non-reactivity or inequality. The posture helps as well, whether it's hypotonia, decorticate, or decerebrate. And that's just a reminder of how do we assess, children under an emergency situation. That applies to anaesthetists in anywhere, including the in theatre. And remember the temperature, because it tells you about infection and sepsis, which is very, very serious in children, and convulsions, febrile convulsions, quite common in children, rash and bruising because of allergic reaction, septicemia, and infection with rash, obviously. Let's go into the meaty and important thing, and I hope that we've got some of the attendees, of our colleagues, who are now interacting with us. The first scenario, which would help and stimulate us to think about the emergencies, a 2-year-old child coming for circumcision.
Dr. Mu'taz, sorry for interruption. Do you want attendees share with you the discussion?
Yes,
now?
yes. I understand. Yeah, I understand that we've got 20 or 25 colleagues who are on with us.
Okay. You please, attendees, colleagues, you are allowed to ask questions and interact with Dr. Mu'taz in the upcoming scenarios.
I would ask you, Professor Manal, if you don't mind, if somebody actually writes an important question or something, because I can only see the presentation. I can't see my the comments. It's very difficult for me to see that. I will try actually, but I hope. Yeah.
I will inform you about the questions at the end of each scenario.
Okay, I try to get the question.
To not interrupt. Okay.
Right.
I see the question. 1 minute.
Okay, I've got Q&A questions here. Right, participants. I can see the participants here. Okay, but I can't see comments, so I'll just close the comments. I've got Q&A here. I can see the Q&A, but I would leave you to guide on the questions.
Okay.
And answers, yeah.
1 minute to open the Q&A. I have a problem to open them.
That's fine. Okay. I'll carry on with the presentation.
Okay.
Yeah?
Okay.
No problems. So the first case would be for a 2-year-old child coming for circumcision. That child had an inhalation induction. He had a 22 gauge cannula sighted into his hand. We tried a laryngeal mask size 1.5, which proved to be leaky. So we went to size 2. There was no leak and it was easy to ventilate. A penile block was performed by the registrar, and the child was taken from the anesthetic room to theatre. We use anesthetic rooms in the UK most of the time. Sometimes we don't use them, but most of the times we use them, hence from anesthetic room to theatre. In theatre, following the start of the procedure, please note the parameters down there. The saturation of this child went down from 99 to 89%. The heart rate went up from 116 to 142. Blood pressure is 92/64. The end-tidal CO2 was going at 25 millimeter. The chest, having listened to it, there was a bit of a bilateral diminished air entry. And trying to bag the child, it proved to be difficult to bag. Now comes the point where people can share. I'm not sure if they are there or not, but we need your thoughts about this. Can somebody tell me what would they think that could be? Is anybody with us? Professor Manel? I can't see Professor Manel though. Right.
Yeah, we are here. I think laryngospasm.
Who is saying that?
Anahita.
Right, you think laryngospasm. And why do we think it's laryngospasm? Can somebody else try to let us know? What can cause laryngospasm here? What's the issue? Why did this child, why do we think there is laryngospasm?
Dr. Saad, excuse me, I can't hear the questions. I have a problem to open the question, Dr. Saad.
Can you check the chat, please?
Chat, okay. Okay, Dr. Mu'taz, Asma, Dr. Asma Badawi ask you,
yeah, somebody mentioned LMA position, so that could be a malposition or disposition of the LMA, which I accept. That's good. I think it's due to laryngospasm. I had laryngospasm here, and the laryngospasm may be due to light anesthesia, as it happened with the start of surgical stimulation. Laryngospasm, anaphylaxis. Somebody said anaphylaxis, start ABC. Laryngospasm versus anaphylaxis, light inadequate anesthesia. I like all these answers. Positioning of the LMA would be my first thoughts, and we reposition the LMA. Still the same problem applies. Now I'm thinking of laryngospasm, which could give you bilateral diminished air entry. Somebody commented and said it's in the beginning of surgery. That is correct. It's the beginning of surgery. But again, in the beginning of surgery, they should be deep. But what we note here is that we've put a penile block, and we depended completely and solely on penile block for the circumcision. There is no opiates given. There's nothing else in terms of analgesia. So if we think down the route of laryngospasm, then what do we do? Who wants to volunteer? You can write or talk. I'm quite happy. I can see your answers here.
what's the question, Dr. Mu'taz, please?
Yeah, the question is on the screen. What to do? So I've got an interesting one, bronchospasm here as well, and aspiration. Thank you. Yeah. Aspiration as well. Thank you. Aspiration, malpositioned LMA, bronchospasm. Increase the depth of anesthesia. That's one. Okay.
Ketamine.
Remove LMA. Thank you. Ketamine. Thank you.
Ketamine.
Deepen the level of anesthesia. So ketamine, deepening the level of anesthesia are all things which we would like to do. Small dose of propofol. Thank you very much. That's excellent. Give 2 milligrams. Why specifically 2 milligrams? 1 to 3 if you want, but that's good. Deep anesthesia, if not reversed muscle relaxant. Okay, thank you very much. So How about high flow oxygen? 100% high flow oxygen. Yes, I would start straight away with this. By the way, during an emergency, you're not going to think about one thing and wait for another 2-3 minutes and do the other thing. No, high flow oxygen. Yeah. How about CPAP? Do we agree? You're actually symptomatically treating what you've got of desaturation and what you think is an upper airway obstruction or an airway obstruction generally. How about fentanyl? Is it good? It can work, but that will take us some time. We think that we're lacking analgesia, and some people will reach to a fentanyl or morphine to give it, which is a good and excellent analgesic, but maybe not an emergency situation or near emergency situation. Increase the inhalational concentration and give a small dose of propofol. And I'm not actually telling you anything. I've got all, thank you, Khalid Balla, all go simultaneously, Doctor. Excellent, definitely. Deflate the stomach, I like this as well. High positive airway pressure, excellent. That's very good. Yes, propofol 1 to 3 milligram per kilo. Increase the inhalational concentration. All go simultaneously. A muscle relaxant. If things don't go well, do you want to give a muscle relaxant? Yes. Which muscle relaxant? Anybody wants to volunteer? Yeah, straight away. Yeah. Anybody wants to type it? Yeah, muscle relaxant. Which muscle relaxant? Choice.
Succinylcholine.
Succinylcholine, succinylcholine. Anything else? Any other takers?
Rocuronium suggestion. Rocuronium, succinylcholine. Rocuronium.
Atracurium. Right. Let's go around all this now. Right. Okay. So we've got sux or succinylcholine. We've got rocuronium. We've got atracurium. Which is the best? I don't know which is the best. Rocuronium might be a good thing if you've got Sugammadex. Yes, give a dose, but you need to give a big dose for it to work quickly. If you want it to work quickly, you need to give a decent dose. Sux, this is the classic one. But remember something about sux. What is it about sux? If you give sux in hypoxemia, you're risking bradycardia. But sux is the gold standard up until now. So if you give succinylcholine or succinylcholine, then it is the gold standard. Somebody said bradycardia here. Excellent. I like that. I like that. Well done. So I myself, if I've got rocuronium, I would give a big dose of, or a decent dose of rocuronium, 1.2 milligram per kilo. You can actually intubate with 0.5 milligram per kilo, but you'll have to wait for more than 1 minute maybe. If you intubate with 1.2 milligram per kilo, then you would be able to intubate with this if you're going to intubate. Some people give a small dose of succinylcholine, 1 milligram per kilo or 0.5 milligram per kilo, on the premise that hopefully it's not going to cause bradycardia and it will relax the cords for them to be able to still ventilate without intubation. Maybe that does work. But if I reach this stage, I would give a decent dose of rocuronium or a decent dose of succinylcholine, which is still the gold standard and classic. Well, somebody said low dose sux preceded by atropine. Maybe I've got a little bit of a lag here. Thank you very much. I like that. Preceded by atropine. It would be expected from pediatric anesthetists to have on the table atropine and to have succinylcholine handy. And when I say handy, means you do, some pediatric anesthetists do draw it up in a syringe, which I respect, or others keep it very near so that you can break the ampoule and draw it and give it. So the gold standard would be sux, or if you have Sugammadex, you give rocuronium. Right. Anything else you can do? I'm going to actually, and obviously intubation or no intubation, it's up to you. You might actually give a small dose of sux and some propofol. You break the spasm, you deepen the child, you tell the surgeon don't touch the child until you give a dose of opiate, morphine, if you don't have fentanyl, and then you go back again and do the whole thing, or you intubate and forget all about it and get it going. The other way, is there anything else you can do? Oh, I've put this. What do you think about doxapram? Is there a rule for doxapram? There is a rule for doxapram, but maybe not in this situation. It will come. So that's laryngospasm, obviously. And remember doxapram. Okay. If you stimulate the larynx, you get glottic closure, airway obstruction, hypoxemia, bradycardia, low cardiac output, and cardiac arrest. And you want to avoid all this. What are the predisposing factors? Young age, upper respiratory tract infection. So children, and it's always a big debate whether we actually anesthetize children with upper respiratory tract infection or not. For elective procedures or for emergency procedures, you cannot do anything at all, obviously. But yeah, lignocaine, thank you. I'm going to come to this. Have I used laryngoscopy? I'm not sure if this poll relates to me. Yeah, but that's fine. That's the next lecture. So the predisposing factors, I mean, upper respiratory tract infection, again, in the first week and up to the second week, you are very highly going to get some sort of laryngospasm. You decide to do it maybe after the second week because the airway clears after 6 weeks from the upper respiratory tract infection. Maybe you want to do it after the second week and you know that you might get a laryngospasm anticipated and you're going to manage it. Children with asthma or atopy, passive smoking in the family. If you're doing some airway surgery, it goes without saying, and somebody's actually put anesthesia for the airway, which is lignocaine. Yes, if you're doing airway surgery, and that's going to come as well, then you anesthetize the airway, and that's where the lignocaine comes into the equation. Somebody's asking about sublingual dexamethasone in emergency. The answer is yes, but if I have a cannula in, then I would use it intravenously. Very recently, one of my colleagues used intramuscular. She was putting a patient off to sleep with through inhalation induction, and the child proved to be very difficult to ventilate. So she gave him a dose of intramuscular dexamethasone. Yes, intralingual does work. The times I used intralingual one time because it's like an intravenous route. The intramuscular route works. It does take a little bit more than the 1 minute, the usual maybe 2 minutes or something like that, but it does work if you give a decent dose, 5 milligram per kilo or something like that. It does work as well intramuscularly if you're worried about anything to do with the tongue. Remember the predisposing factors as well. Secretions, blood, debris, edema of the airway, inadequate depth of anesthesia, endotracheal intubation, manipulation. If you actually manipulate the airway without giving a muscle relaxant in a semi-deep child, you risk a laryngospasm. And post-extubation or during extubation. Again, a colleague here is asking about dexamethasone. Of course, when you have something like that, you'll end up giving dexamethasone. But remember, dexamethasone is not going to immediately work and get you out of a laryngospasm. It's got a role to minimize the edema for afterwards. And yes, you probably want to give it. How do you prevent the whole thing? Do a good assessment, anticipate the risk. Never manipulate the airway during light anesthesia or the in-between stage. If you're just thinking, remember to manipulate the airway, you need to have the pupils small, very small, and you need to have the eyeball centralized. You open the eye, have a look at the eye of the child. You need to see the child looking at you, not looking down, not looking up. If they're looking down or looking up, that means they are not deep enough. So they need to be central, looking at you, and the pupil needs to be very small. Always maintain a clear airway through suction, removing foreign bodies, and what have you. And some people adopt fully awake extubation. If there is an indication to extubate deep, then it needs to be very deep extubation, which means extubation at a level of surgical anesthesia. Okay, we'll move on. And then anesthesia to the airway, which is obviously topical anesthesia or a block, if you really, but what it means here for the prevention, if you're going to do some work on the airway, you have to anesthetize the airway. There's no way you can just not anesthetize the airway and do your surgery. Scenario 2, very quickly. 6-year-old girl admitted late night with moderate to severe abdominal pain. The surgical team planned an appendectomy and possibly a laparotomy. And because she had been dehydrated and not fasted, the decision, I mean, she came late night, the decision was made to give her some fluids and take her to theater in the morning. She'd also been vomiting all the way through. She was taken to theater the following morning and had a GA. She did have a rapid sequence induction, and some people call it crash induction. We do cricoid pressure here in the UK. Some people don't, like in France. And she had thiopentone, succinylmethonium, sevoflurane, coamoxiclav, which is augmentin, fentanyl, and morphine. She was given all this. The surgeon started and noted and told you that this is a difficult and swollen appendix. And then you were asked to help in theater. You were not the anesthetist at the time, but you were asked to come into theater to help because she was hypotensive despite the fluids she was given. She was given Hartmann solution 20 ml per kilo and a bolus of gilofusine 20 ml per kilo was ongoing. The heart rate 129, blood pressure 52. She's 6-year-old, 52 over 28, saturation 92, and your oxygen saturation was 80%, and the end tidal CO2 was 33 millimeter mercury. Yeah. What do we think? Anybody wants to volunteer? Oh, severe sepsis, that's good. How about the chest? I like that. Anaphylaxis, how about the chest? How about the chest? Septic shock, sepsis. So hypotension. And remember, we need to default back to our assessment, if you remember. Anything, even in the OR, and we're an anesthetist and we can actually see everything very quickly, you need to go back to the assessment. And the colleague who's asked about the chest is very, very, very legitimate here, because obviously this picture could be sepsis, could be anaphylaxis, could be severe hemorrhage. Could it be? Yes, could be severe hemorrhage. Why not? Carcinoid syndrome and intussusception. Yes, intestinal obstruction can cause this. That's for sure. Right. So we're all here about assessment. So that's the chest. Bilateral wheeze all over. That answered a lot of your questions, didn't it? Again, difficult bag ventilation because the airway pressure is high. Look at that. Remember exposure, which we talked about. The colleagues who said sepsis is not wrong. Yes, this could be sepsis, particularly it's an intra-abdominal pathology and it's appendix and it's difficult and it's inflamed and it's infected and all this. Yes, indeed. You'd be really unlucky to have sepsis and wheeze as well, because sepsis might come with some bronchi and crepitations, but not necessarily wheeze. So hypotension and wheeze go, and rash on the chest goes more with, anybody wants to, hypovolemic shock, yes, I like that. Temperature was normal, thank you very much. Aspiration, pulmonary edema, anaphylaxis, electrolyte discharge should be corrected, especially with vomiting, thiopentone, morphine, antibiotic. Thank you very much. Somebody's trying to tell me that they've got thiopentone, morphine, and antibiotic. Yes, if you look at this, if we go back, she had thiopentone, she had succinylmethonium, she had coamoxiclav, and what is that? What is that? So go back again. What is that? Gilofusine, quite famous for causing allergy and anaphylaxis. So all the differential diagnosis was correct. I cannot disagree with anything. And presumably your immediate treatment would be what? Would be similar if it's sepsis or anaphylaxis. This was anaphylaxis, and here you are. And I refer you to this, which is the AAGBI, Association of Anaesthetists of Great Britain and Ireland guidance. And that's the latest and up-to-date one. You got the websites there. And that was 2019, the 2019 one. What do you do in this circumstance? Obviously, you've got hypotension and you've got bronchospasm. The one agent which is very helpful and do it all is adrenaline. Again, what's the dose of adrenaline? It depends. They teach non-anesthetists to give it intramuscularly. If you have an intravenous cannula, then I would give it intravenously. Yeah, and I would go 1 microgram per kilogram, 1 microgram per kilogram, and I would give this in titrated doses. Would I repeat it? Yes, I would keep repeating it, and if I stop it and there is hypotension, then I need to give it as an infusion, and that's the immediate treatment. Yeah. Later on, you can give hydrocortisone or chlorpheniramine. The dose is in front of you. Don't forget, which is very important, to do your tryptase test. So take one straight away and repeat it at 2 hours and then 24 hours. And if it comes positive, you know what your diagnosis is. If it doesn't come positive, still I would say it is anaphylactoid to any of these agents. I would send the patient later on for assessment and for testing, and I would tell the immunology specialist or the allergy specialist that this child has had these drugs, and I would actually give them all. How about subcutaneous adrenaline? You're better off with IM, intramuscular adrenaline. You're better off 1 microgram per milligram. I'm not sure, maybe he meant 1 microgram per kilogram, but yes, you're better off with the intravenous followed by the intramuscular, because you will get it into the circulation better, and then maybe you know, I wouldn't think that the subcutaneous would be as effective as the intramuscular. But obviously, if you can't do but give it subcutaneous, give it subcutaneous, because in the community, we give people something called EpiPen. I'm sure whoever works in the UK or Ireland will know about that. And they are actually advised, and the mothers are advised to give subcutaneous adrenaline, which they carry in their bag all the time. And the way they give it subcutaneous. But in theater, you've got an IV access. Just go for it straight away. Yeah. Remember, unexplained hypotension, unexplained bronchospasm, with maybe absent if severe, you have a silent chest, and unexplained tachycardia or bradycardia, you're heading towards the anaphylaxis. Give the adrenaline, even if it's sepsis, you're on the right path still. Are we okay with this? Right. I'm not sure about the time.
Actually, we're beyond the time now.
That's fine. I thought we've got up to past. It's 28 past now. So I'm happy to take any other questions later on. The other scenario was going to be for people to remember it very quickly. I've put the slide, and if you give me another minute, I'm not going to talk a lot about it. And that was a foreign body in the airway. Yeah, and the symptoms will be you've been asked to see a 3-year-old in A&E with history of cough and some respiratory wheeze. On admission, there was respiratory distress with tachypnea, tracheal tug, subcostal indrawing, and working accessory muscles of respiration. The respiratory distress is settling now. The mother gave a history of him going blue, which means cyanosis, when she was feeding him a boiled egg, followed by the history as above. His saturation now is 98, but he needs half a liter of oxygen to maintain his saturation. I'm just going to, basically, this child will need an emergency bronchoscopy. The bronchoscopy, we do it, obviously. I've got very nice pictures and everything here. I'm not sure if we've got the time for it, but you don't give pre-medication, you go for inhalation induction. Some people go for intravenous induction. I like to go for a hybrid technique, which means I tackle the airway with a foreign body via sevoflurane, and I've got a cannula as well. And if I need, I will augment it with propofol. So I've got both worlds. So quickly I can deepen them if I need, and I keep it quite calm so that the child does not have any issues with a with irritation and moving what do you call it, and moving a foreign body which was distal, which was proximal to a distal. I'll show you this video. I'm not sure if you can see this on the screen, but I will try to make it as big as I can. I'm not sure. No, it's not gone. It's not gone the way I wanted. So apologies for that. So I'm just going to do it there back again. Can you see this on the screen at all? On my screen in the middle, can you see it?
Yes, Professor.
Yes. So basically, this child did have this in his larynx, and that was an egg shell crack. That was the cover of the egg when mom was giving him the egg. That went in and went into the airway, as you could see. And the way we did it is we went for a tubeless field. We put a nasopharyngeal tube short of the larynx, as you could see, and we got the surgeon to go in with their instruments through a tubeless field to pull out the egg shell of the airway to clear it. You need to give dexamethasone. You need to have adrenaline handy for nebulization. In recovery, your enemies are edema of the airway and blood and debris from what it was left. Dexamethasone, adrenaline nebulization will ease the edema and open the airway up for you. Thank you very much.
Hello.
So,
Okay,
yeah.
Thank you, Dr. Mu'taz, for this informative lecture and interesting topics. There is two minutes for further questions if audience need. General questions not related to the scenarios but related to the topic. Okay, we have 2 minutes. Okay, thank you, Dr. Mu'taz, again. Now, the next lecture will be lectured and presented by Dr. Muhammad Al-Tahan. Okay, by Dr. Muhammad Al-Tahan, titled Dr. Muhammad, Professor of Cardiothoracic Anesthesia and Surgical Intensive Care, Mansoura University. I'm honored to present Dr. Muhammad. Dr. Muhammad will talk about an interesting topic for all anesthetists, especially pediatric anesthetists, pediatric difficult airway. تفضل دكتور محمد.
Thank you, Prof.
One second, Dr. Muhammad, please, if you don't mind. I have a comment from our senior colleague from Saudi Arabia, Professor Dawlatli, about Sugammadex. Before 3 years, it is off-label, and it is unclear using of Sugammadex before 3 years. He would like to pass this comment to everybody from his kind. Thank you, Professor Dawlatli, for your comment. All floors for you, Professor Muhammad. Thank you.
Thanks so much. Thank you, Dr. Saad, for your great efforts to implement this initiative. And thank you, Professor Manal, for introducing me. During the following 40 minutes, I'll talk about the pediatric difficult airway management, the role of video laryngoscope. First of all, I declare I received the free airway device samples from AMBO US and AirTrack UK in 2014 and 2015 for use in published studies, and I have no direct financial or other interest in AMBO, AirTrack, or any other industry in the context of this lecture or my studies. I'll go to introduce the world and new era of video laryngoscopes in pediatrics, and emphasizing on applications, advantages, disadvantages, and types, and then try to address and answer for the alerting question, which is best to reach for a conclusion. First of all, the concept of video laryngoscopes was born secondary to the advances in telescopy. Telescopy started from rifles and military, used by military, as you can see here on the left side, and also by our colleagues in endoscopy suites, and as well as in laparoscopy, endoscopy. They are introduced, they're going to using these advances in telescopy for laparoscopy, for thoracoscopy, and so on. The same concept came for laryngoscopes. You know, we are using direct laryngoscopes, which need alignment of different axes. I'll show you to get the best view. However, there are two main types of video laryngoscopes. Either fiber optic laryngoscope with a cable, as you can see here, is connecting the image from the tip of the blade to a remote screen. Or another one is a digital laryngoscope with the microchips in transmitting the image to also to the remote screen attached to the handle of the scope. We have three poles. You need to address them. Can Dr. Saad start with the first pole, please? Dr. Saad? Okay, here I have a question for all of you. Have you ever used a video laryngoscope in your clinical practice? Regularly, occasionally, rarely, never, not accessible to you? Can you click one of them, please? Can we take a look for the results?
Share now here. Do you see the result now?
Yes. As you can see here, most of, about half of respondents are clicking on the regular using or occasionally using. At least we have about 70% or more are using video laryngoscopes. Interestingly, we have 9% as they don't have accessible video laryngoscopes. We'll go for the next one. We have the next poll. Have you ever used a video laryngoscope for a pediatric patient regularly, occasionally, rarely, never, or not accessible? Dr. Saad, please.
Just 1 second, please. I try to share the second one. Just 1 second, please. What is the second? I need to get that. For some reason, I was able to get it. This is the first poll. We need to go to the second poll. No, I couldn't get the second poll now.
No problem, it's okay.
Okay. So
While I
the result on the chat, they can see that in the chat.
the first one, the first one is the first poll.
This is the first poll, Dr. Saad.
I understand, but you can do that one in the chat. You can
intubation, including 13 children's hospitals in the United States between August 2012 to 2015, and January 2015, including more than 1,000 pediatric tracheal intubation. You can see here. Can you move it, please? You can see here we have only about 20%, 1/5 of respondents are using indirect laryngoscopy, video laryngoscopes as the first choice for tracheal intubations in pediatric, which is interesting. If we take a look for applications, that would be a first choice for elective oral as well as nasal intubation in pediatrics and also units. Here is an interesting case report for nasal intubation in a pediatric patient who was large. Okay, we have a poll here. Can we respond to it? Have you ever used video laryngoscope in a pediatric patient? Regularly, occasionally, rarely, never, not accessible. Can you choose one of these answers, please?
It's 120 answers.
Yeah, please can you take a look for results?
16 regularly. I will show you now.
Okay.
Now you see that?
Okay, this is very interesting. You can see we have about for more than 40% are not using video laryngoscope, or we don't have video laryngoscopes accessible for pediatric patients. I think that's much more than this United States study, including 18% of people are not using the video laryngoscope as a first choice. We can proceed. We are still talking about the application of video laryngoscopes and as a first choice for intubation for oral. And here in this case report was a large mass in the mouth, including the mouth for the nasal intubation. Additionally, using Dokuji for nasotracheal intubation for children less than 18 years is recommended to be better than with the CMEC, which is one of the video laryngoscopes that I will address later on. It reduces the complications. You can see the using of Okuji with here, as you can see, the using Okuji with the CMEC is associated with significantly less bleeding, nasal bleeding. And additionally, you can see patients' ages ranging from 8 years up to 66, including both pediatric and adult patients. Anticipated difficult laryngoscopy is another indication for using video laryngoscopes, or even for unanticipated difficult laryngoscopy. If we go back for the best difficult airway society algorithm for difficult airway management in children aged 1 to 8 years, and you can take a look here for step A for initial tracheal intubation plan when the mask ventilation is satisfactory, you don't have a problem in ventilation. With more than 4 attempts using direct laryngoscopy, you have to consider using the Okuji, straight plate, or video laryngoscope. So this is for unanticipated or anticipated airway difficulty. Thoracic surgery you need for pediatric patients, you need to isolate or separate the surgical lung. So the small kids less than 6 to 8 years or 6 years, usually we are using blockers. Blockers, particularly for infants and small kids, it will be difficult to be introduced through the lumen of endotracheal tube because of the small diameter of the tube and the smallest available diameter of high flexible bronchoscope, just 2.6 or 2.7 millimeter. So in this case, placement of bronchial blocker directly through the glottis to intubate the patient with blocker and then introduce the endotracheal tube alongside. was inserted outside to the tube using a CMEC from Shores. As you can see here, the blocker is going directly through the glottis before inserting the tubes, and the tube is inserted alongside the blocker. Also, for a flexible for bronchoscopic intubation in pediatrics, you need either to go through nasal airway or to introduce a laryngeal mask as an introducer for your fibroscope, or as a conduit for a flexible bronchoscope. Using any of the channeled or traditional blades, video laryngoscopes could be helpful in such case. Here is one of the traditional curved blade glide scope is used in 2 years old pediatric patients, and you can see here in the simulation mannequin inserting of the video laryngoscope and fiber optic bronchoscope will be inserted alongside the blade. The benefit here, you are investing the presence of video laryngoscope to taking the soft tissue and tongue away from your passage, and you have to go directly to the glottic opening, facilitate endotracheal intubation. Also, we described before using king vision plates with the channel plates with the fiber optic bronchoscope for facilitating of intubation in adults and pediatrics. Awake tracheal intubation directly using video laryngoscope. Here is a case report using a CMEC in such patient with severe craniofacial malformation secondary to amniotic band syndrome, and in this case they take awake lock with a video laryngoscope. Here it might be there is a concern why they didn't intubate directly, as long as they can see the glottis before much of anesthesia. Awake intubation using the video laryngoscopes is well known, and here is reported in 10 years old boy with morbid obesity and multiple comorbidities was diagnosed at 37, and awake intubation was accomplished here successfully. We have here one of our cases involved, and this is a large mass, including the mouth opening of the tongue, and you can see the mass is protruding from here. If we take a look here about towards this video, you can see with the awake intubation, you can see the laryngoscope is inserted beneath the mass and above the tongue. So the mass up here is the mass, it is not the tongue. And with the laryngoscopic guidance, we advance the tube into the glottis with some navigation to facilitate passing of the tube. And here the patient is awake after intubation using a laryngoscope. Training of novice practitioners could be facilitated with using of video laryngoscopes because we have a remote screen, so you are sharing information between the mentor and the trainees to facilitate. Most of them airway scope compared with a straight blade of Miller blade, it could be successfully reduce the time of intubation in post mannequins. Interestingly, this is secondary to increasing of success rate with using airway scope compared of Miller in this simulation-based study. Advantages of using video laryngoscope, eye and airway need not line up, because as you know, if we take a look here for this X-rays, we have a tracheal axis, we have a pharyngeal axis, and we have oral axis. To use direct laryngoscope with Macintosh or Miller plates, you need to align all of this axis to take a look directly into glottis. However, with video laryngoscopes, like a channeled video laryngoscope here, we can see the two axes, pharyngeal and tracheal axis, are almost aligned together. So there is, and you are looking to a remote screen, not directly into glottis. So this is the advantage of using a video laryngoscope. Here we have what's called external angle between the Macintosh plate and the tracheal tube. Here is the angle is 20 degrees, but it is reduced to minus 20 with using of channel video laryngoscope on the right image here. The problem of alignment of the three axes, if you have a patient with limited mouth opening, like this patient with congenital malformations, pediatric patients with morbid obesity, cerebral palsy with neck deformity and fixed rotated head to right side, patient with arthrogryposis, or patient with mucopolysaccharidosis syndrome, or patient with microcephalus occlusive syndrome. All of them, video laryngoscope successfully used in them. Also, it is helpful in case of limited accessibility. For example, if you are going to anesthetize the patient in the MRI suite or in CT suite and using old machines, which is a longer one, and the head is not accessible for you. If you are going to anesthetizing a patient in prone position and there is the problem in your tube, using a video laryngoscopes could be helpful here. We described using of tracheal intubation in prone and lateral position in a patient with encaphalocele using a gyroscope. Also, other benefits, others can see and help you. If you have a difficulty, you need some advices from others, they are sharing the image on the remote screen and can help. Also permit sharing of medical information among team for during one of intubation. You might found, like we found here, some papillomatosis, and you call EMT surgeon to take a decision and change the surgery for the patient. And same if you have a tracheal web discovered during intubation, during kaleidoscope, as you can see here. We have a disadvantage for video laryngoscopes. They are not angels anymore. There are variable learning curves, which may take longer to intubate. The problem to take a longer time to intubation, particularly in pediatrics, that you are going to expose the pediatric patients to risk of hypoxemia. By building up of learning curve and increasing the experience and the skills gained by practitioners, this time to intubation is expected to going down. If you take a look for this study, including 77 operators with various experience in pediatric tracheal intubation, performed 10 attempts of tracheal intubation using gyroscope, AirTrack, McGrath. All of them are video laryngoscopes. You can see the time to intubation is significantly decreased, starting from the third attempt here, and also from fifth attempt. So the time of intubation is decreased from the first trial up to the 10 trials. The 10 trials, that's meaning you have a 10-time experience. That's the beginning one. Ease of intubation also is decreased from the third attempt, as you can see here on the left side. The passage of tube may difficult despite grid view. You have to put in your mind a good visualization of the glottis doesn't translate anymore to ease of intubation. You can get a perfect view with a video laryngoscope for the glottis. However, your tube, because of its natural curve, it's going to the esophagus. That's why you are usually advise your colleagues to get the tip of laryngoscope away from the glottis. You need to sacrifice with this optimum view to just a good view to allow the natural curve of the tube to going anteriorly to the glottic opening. As you can see here, we have a good view. We are sacrificing with excellent view for the glottis. We keep the tip of gyroscope away from the glottis because otherwise you have the tubes going directly to esophagus rather than to glottis. Fogging and secretions may obscure view. There is a simple trick. Just turn on your video laryngoscopes for 45 seconds or 60 seconds in advance of intubation. That leading to heating up of the bulb or light source of the camera and avoid leading to vaporization of fogging and secretions from it. And do suctioning before inserting your video laryngoscope. Some video laryngoscopes, as I described, are associated with inherent anti-fog mechanism. Loss of depth perception. You might know our colleagues in surgery, they are training them to be skilled in moving of hands using clamps and cutting, doing cauterization and so on in a distant place on the remote screen. There's the same problem here. We have a loss of depth perception needing to more be skilled in using video laryngoscopes. What is the problem? If you are focused on the screen and you are going to introduce the tube without looking into the mouth of the patient, that's leading to software palate injury, soft tissue injury, anterobellar perforation. This is why we have usually 4 golden steps in using any video laryngoscope, particularly for the curved blade laryngoscopes. You have to first look into mouse while introducing the tip of the scope, then look to the screen for the clotting image, and then introduce the tube while looking into the mouse to avoid injury of lingual nerve or pillars or soft tissue by the tip of the tube. And last step is look to the screen to direct your tube to the glottic opening. Here are just an example, some examples of pillars infiltration. You can see here is the hypopharynx. Here is the anterior pillar, it's perforated by tube. Secondary to using of different laryngoscopes, video laryngoscopes, glide scope, air track. And also in our theater, we have one reported case, as you can see here. We use the titanium glidoscope blade, and there is a perforation of the anterior pillar during insertion of armored reinforced tube, required repair and the changing in patient's voice after surgery. So it is a hard lesson to be learned. We are talking about a more complicated technology and very expensive technology indeed. We have many products, many suites available in market, and much confusion. I can summarize the type of video laryngoscopes into 3 main categories. Stylets, which like any stylet you are using, but this is a video stylet. And we have a guide channel, this video laryngoscope with a channel alongside its blade to introduce the tube thyroid. Or traditional modifications for our commonly used Macintosh blade, which is a curved blade. Usually, we are reserving stylets and guide channels for patients with limited mouth opening or limited cervical movement. The next poll, Dr. Saad, please. Dr. Saad. Okay, the question, if you have access to video laryngoscope, which of the following types of video laryngoscopes are used in your practice, particularly in pediatrics? Stylet rigid video laryngoscope, a video laryngoscope with a guided channel, a video laryngoscope with an angulated curved blade. Please click on your answer.
Still signing.
Okay.
Okay, end now. Okay, it's here now.
This is very interesting. You can see about half of respondents are using video laryngoscope with angulated blades, and 1/4 or more than 1/4 are using guided channels. About 20%, 22% are using stylet rigid laryngoscope. This is very interesting indeed. And here I'll go to the next slide. We'll start with the stylets. We have 2 types available in market up to the best of my knowledge. Bonfields and multi-view system. Bonfields coming from stores, and they have portable light source, or you can use any light source from Pentax or even stores or even Pentax at your theater. There is eyepiece here. There is a piece to providing option. You can see it is a rigid plate, and we have also an angulated tip here. There is an eye tip. Usually it's connected to camera system. It is available in an angle of 40 degrees. Here is the 40-degree angle. And there is 2 sizes available. Size 2 can be used with tube 2.5 to 3.5 for first year kids. And above first year, you can use 3.5, which can be used with endotracheal tube size 4 to 5.5. There is a case report about using Bonfields for endotracheal intubation in a patient who is 8 years old with temporomandibular joint ankylosis. Also, this is another mannequin study. You can see here a mannequin study in 2 scenarios, with easy scenario and difficult airway scenario with increasing the Cormackley hand to grade 3B. You can see bone fields as comparable time to intubation with direct laryngoscopy during normal and simulated difficult airway. However, success rate is 100% with bone fields. This is a study including 150 intubation by 10 anesthesiologists using a tube size 3.5. You have to put in your mind the size of tube is one of the most important independent factor which can determine the success rate for intubation. The smaller the size of the tube, the higher the success rate. Another study including 60 trainees with 5 trials with endotracheal tube size 3, comparing bone fields and regular rigid bronchoscope in 3 scenarios: normal airway, anterior larynx, or Pierre-Robin syndrome. The time of intubation is significantly decreased from the first trial to the 5th trial. And there is no big, and there also time of intubation is longer with bone fields compared with the rigid bronchoscope. This is a normal and anterior larynx simulation. And same differences are reserved in Pierre-Robin simulation as well. This is the video demonstration for using all Stalets laryngoscopes. This is an example of using of bone fields. You can see the cameras connected to the tips there. And, and light sources connected here. Here is the shaft. In all video laryngoscopes, you need to lubricate the blade or shaft of your video laryngoscope and endotracheal tube. Here is the endotracheal tube is going to be loaded over the tip of video laryngoscope after turning off light source. One of the golden tip here is the holder for the tube to fix it. And you can see this part, you can apply oxygen to the patient. One of the most important points, you have to avoid that the tip of Stalet is going outside the tube. Otherwise, you are going to injure the patient's soft tissue. It shouldn't be like this. It should be retracted inside the tube, as you can see here. And then you have to use a traditional direct laryngoscope just to remove the tongue away from your passway and introduce the bone fields with the tube overrolled over it, alongside the right side of the plate behind the molar teeth is called bone fields retromolar endoscope. And you started with angulated to the left side until you found the glottis, then rotate yourself to make the angle angulated forward. And then introduce the tube inside and get your Stalet outside. The next one of the Stalets is multi-view. The difference here between bone fields and multi-view is the tip here is deflectable. That's meaning you have a handle in your hand and you can change the angle here. It's deflectable up to 20-degree angle. Here is a 20-degree. You can move the tip up and down like a mobile Stalet, like Schroeder Stalet, if you know about it. The viewing angle is variable between 60-degree plus or minus 50%. There is a portable screen on the handle, it's 2.2-inch LCD screen with 2.5 megapixels. You can apply also oxygen, a continuous oxygen from this port. And we also, it is available in 2 diameters, 2.5 to can use the tube 3 to 3.5 for first year kids, and outer diameter of 3.5, it could be used for endotracheal tube 4 to 5.5. Also here it described using of multi-view scope for 21 months old patient with Schwartz-Jampel syndrome with a congenital malformation of the face. This is an interesting study including 15 expert, 15 resident with endotracheal tube 3.5 in 2 scenarios of normal airway and Pierre-Robin stimulation, as you can see here, using a multi-view. The time to intubation is significantly less with multi-view than comparable and is comparable with different with direct laryngoscopy in both normal and difficult airway simulations. AirTrack We are talking now about channeled video laryngoscopes. We have two types of air tracks available in market: the gray one, size 0, and pink one, size 1. Size 0 for tube 2.5 to 3.5 with a mouth opening up to 12.5 millimeter. Size 1 can be used for tube 4 to 5.5 for the mouth opening, a minimum mouth opening of 12.5. It is a channeled video laryngoscope with 90-degree shape. There is a built-in anti-fog system. Just you need to turn it on, the light source for 30 to 45 seconds. Is low cost, about $90, and single use, of course. You can use any smartphone, either using iOS or Android, with a specific holder to use it as a viewer, and you can transmit images by Bluetooth. Also, there is a Bluetooth piece here. You can take image and you can save and you can record. Also, you can use any stores or Pentax or other video camera for displaying. Here, this is an interesting study, including 83 novice nurses with a mannequin 6-year-old, the BDSM and chest compression system locus, and using endotracheal tube of 5. You can see the time of intubation with PCR and difficult and normal airway, and even without CPR is significantly less with AirTrack compared with Macintosh. Pentax airway scope is coming from Pentax. They are available in 2 sizes. The pink one is the pediatric one, can accommodate tube 5.5 to 7.5. Infantile one is including neonate for neonates, tube less than 5 millimeter. Both of them are uncuffed tubes. The view angle is 80 degrees. This is the largest angle visualization angle available in market for channeled video laryngoscope. There is a channel LCD screen, 2.5 inch with very high resolution and channel plate. Interestingly, there is a crosshair display, like you are going to shoot the tube into the glottis, which facilitates the intubation indeed. Here is a description of using a Pentax airway scope after feeling intubation with McGrath in a 12-year-old girl with golden hair syndrome. Also in this study, including experienced anesthesiologists, more than 10-year experience with more than 50 intubations, and the tube was calculated per age, they found using a Pentax airway scope has a comparable time to intubation with Macintosh, so there is no difference here. However, interestingly, Pentax associated with more teeth injury than Macintosh, than direct laryngoscope. King Vision is another channeled video laryngoscope, is available for pediatrics with also viewing angle 80 degree like Pentax. Also, we have a display screen of 2.5 inch LCD. They have both non-channeled standard and channeled blades with anti-fog treatment mechanism. You can see we have size A, non-channeled, size 2 channeled and non-channeled for pediatrics. Usually size 1 is used for pediatrics less than 1 year, size 2 standard, and size 2 channel used for children 1 to 10 years. Size 3 can be used for more than 10 years. And there is a difference of mouth opening. Mouth opening, it should be as a list of 10 millimeter for size 1. And for standard blade to 10 millimeter, 13 millimeter for 2C. Interestingly, in this study, including 200 patients less than 2 years old by 5 experienced anesthesiologists using King Vision or Macintosh, time to device out is significantly less with King Vision. However, there is no difference between time to intubation using direct laryngoscopy or King Vision, with the trend towards higher time to intubation, but not statistically significant with King Vision. ViviTrack. ViviTrack is interestingly stainless, single use, available in pediatric for endotracheal tube size 4 to size 6, and has a stainless plate anti-fog treatment. Excuse me. As you can see, There is a USB connecting cable. It could be connected to any tablet, to any laptop, computer, or screen, including operating by Windows 7 to 10 or Android 4.42 or greater with integrated USB cable. The next channel video laryngoscope is FlexView. FlexView, as you can see, we have a grip. This grip leading to articulating tip to be moving forward. It is a channeled video laryngoscopes and it's described to be used in pediatrics. Here in this video demonstration, I'll show you how to use any type of video laryngoscopes as an example of the air track. You have first to lubricate the tube and lubricate the tip of a video laryngoscope. Insert the tube through the channel. Turn the light source on. Do suctioning for the glottis to avoid obscuring of your view with secretions. And now insert the scope with the mouse and through the mouse with the display facing the feet of the patient, as you can see. Then advance it in with moving it backward towards you with some twisting movement to adjust the view, and then advance the tube through the glottis, hold the tube in place, remove it from the channel, and get your scope outside. Don't forget to inflate the cuff of the endotracheal tube. Traditional modifications from its name, it looks like our routinely used the Macintosh plate, the curved plate. All of them are coming from the same concept. Copdec VLB 100, it resembles the direct laryngoscope, as you can see here. There is attached screen 3.5-inch red, green, blue over the handle. The angle is too small indeed, is 39. Small angle compared with other curved plates, is available in size 2 and 3 Macintosh curved plate and straight Miller plates 0 and 1 for pediatrics. Stur's CMEC is 60 degree and it is available in also Macintosh curved plate 2 and 3 and straight Miller 0 and 1. There is a very high resolution camera with 15 megapixels, is available in straight and curved plate, as I told you. The angle is 60 degrees. Here is the angle. Also, Sturz introduced a single-use blade with a fiber optic reusable cable and disposable plate, both curved and straight. It's a single-use CMEC S. Here is the angle, 60 degrees as well. Also, there is the portable pocket monitor, which is a 2.5-inch portable screen. And recently, they introduced a versatile CMEC with a portable aside remote screen. It's connected by a cable 50 millimeter in length, and the screen is 3.5-inch. The idea of remote screens, as you can see, it is propagating after the era of COVID-19. Because if you are using video laryngoscope, you have to choose a remote screen rather than the one attached to the handle to stay away from the mouth of the patient in case of infection in suspected or positive patients. CMEC with D blade, the pediatric D blade, is the largest angle for a curved plate available in market. From its name, D, letter D, you can see the angle is 80 degrees, and this is the letter D, because if you draw a line here, you have a D shape. Here is the D shape. In this comparative study in children aged blue or greater than 1 year using a CMEC or Macintosh, any reported complications, there are non-significantly higher rate of complication with CMEC, and however, and there is no difference in first pass success rate in this study. This study including 452 intubations on 422 patients less than 18 years old. McGrath. McGrath is available with a remote screen over the handle. It's 2.5-inch. Is available in reusable and disposable plates, size mag plates, curved plates, 1, 2, and 3. Also recently, they introduced the Maggrass MX blade, which is like a D blade of CMAC with 80 degree. There is a study including 75 novice paramedics using Maggrass with inline stabilization in the mannequin or with a C-collar. You can see the first pass success is 99 with Maggrass compared with Macintosh and inline stabilization, and still high with 93% compared with 45 with C-collar. Glidoscope is first introduced in Canada and including a plastic plate curved to 60 degree. Here is the angle, and had the reflective screen with the high quality screen. We have described the 4-step technique, and I'll show it for you later on. There is a plastic curved to 60 degree. It is available in titanium, Lubro 2 or a disposable plate. Glidoscope AVL, they available for pediatrics in size 0, 1, 2, and 2.5. For Maggrass with Glidoscope Go 3.5-inch landscape, which is available also in size Lubro S1 to 2.5, 0, and 1 as well. For curved plates, 3 sizes, 1 to 2.5, and the straight plate 0 and 1. Copilot, it has a blade with a port allowing introducing a bougie. There is a remote screen, and it is a 4.3 detachable screen. The cheese are disposable, is available in size 3 and 4, and provided with a rigid stylet. Into Bright, it is another traditional modification. It is a stainless steel with a Mac plates 1, 2, and 3. Miller plates, you can see here in this one, this curved plate 1, 2, and 3. Miller is available in 00, 0, 1, 2, and 3. And also Phillips blades 1 and 2. TrueView, and TrueView is BCD is another technology. It is based on the rarefaction. You know, the rarefaction in ocular physiology. It is the same concept. There is optical lens here, and the image coming is you just a rarefaction with a 40-60 degree, and is available in 5-inch LCD and the stainless steel blades. It is available in size 0 for kids less than 1 year, size 1 to 1 to 3, 2 for 2 to 16 years, and size 3 more than 16 years. There is a study including 153 patients less than 16 years old with normal airway. You can see the success rate is 90%. This is observational study, and you can see success rate. It could be translated into optimizing the glottic view. You know, the grade 1 in Cormack-Lehan, that's meaning the best view. 93 of patients are associated with such good view. UE scope. UE scope is available as a touch screen 3-inch, is a single-use plate, is available in size 0, 1, 2, and 3. In this interesting study, compare using mannequin 5 years old with a corpulous CPR system with chest compression and using UE scope for intubation, the first pass success was significantly higher in normal airway and difficult airway, normal airway with CPR and difficult airway with CPR compared with a Miller blade, a straight conventional blade. Also, time to intubation were significantly less in all scenarios of normal and difficult airway with and without CPR using UE scope. Here is a video demonstration for using any type, the standard of using of any type of traditional curved plates. You have to first use a stylet with all of them. Don't forget this. You have to lubricate the stylet. This is the glidoscope. You have to insert that as a glidoscope. The first step, as you can see, lock into the mouse to avoid injury while you are introducing the tip of plate through the mouse of the kid. Then the second step, you have to lock to screen to find the best glottic view. You shouldn't introduce your tip too far in. Third step, look into the mouse again while introducing the tube, and fourth step, look to screen when the tube is going towards the glottis and the view area over the screen. And then introduce the tube, remove the stylet, hold the tube in, inflate the cuff, and remove the blade. Now, as you can see, we have many types, much confusion. So we have stylets, we have guide channels, and we have traditional modifications. So many products and much confusion. So which is best? This is a difficult question to be answered because there are few studies comparing them, and most of them are mannequin studies. Here in this study compared glidoscope here in 50 and about 100 patients with Bonfils retromolar laryngoscope. You can see the glottic view, Cormac-Lihan grade 1, which is the best view, is more with Bonfils and glidoscope, and also BOGO. Excuse me. It is the percentage of optimum glottic view. It should be 100%. If less than 100%, 0%, that's meaning all patients or this 44 patient have 100% best view using Bonfils. This is the 100 patients with normal airways. As the comparative study between AirTrack and glidoscope for a time including 26 pediatric intensive care clinicians with diverse experiences, and they used GVL glidoscope with AirTrack on mannequins. They found time to intubation with significantly less. You can see it is a big difference between 19.5 seconds to 46 seconds using glidoscope. That is thanking to not the AirTrack per se, but for anyone of channel video laryngoscope, the presence of channel facilitate just you are introducing the scope to the tip and then the tube going through the channel directly to the glottis. So this is thanks to the channel of this guided laryngoscope. This study including 65 anesthesiologists and 15 practitioners, and also pediatric critical care medicine. They are experienced with using of each device. They're comparing King Vision, D-blade of CMAC from Shores, and conventional curved Macintosh and straight Miller. They are using two stimulations, normal airway and difficult airway with limitation of neck movement with something like a neck collar. You can see there is a big difference here in time, statistically difference here, but I think it is unreliable study to found a difference of 1.5 seconds between King Vision and CMAC with a p-value of 0.01. So I would overlook this study. In another study, including 45 novice anesthesiologists and anesthesia nurses, using a 3 to 6 months AirSim mannequin with Pierre-Robin anatomy, they found time to intubation was significantly less using Miller plate, of course, but you can see in McGrath, there is no difference between CMAC with a Miller straight plate and McGrath. It's an interesting study, including 107 novice paramedics using endotracheal tube size 5 and 6-year-old mannequin with chest compression using locus system. They compared Cobdeck, Co-Pilot, Entoprite, and the traditional Macintosh plate. They found time to ventilation are comparable. There is no difference between the 4 groups. However, if you take a look for time to intubation was significantly less with Co-Pilot and Cobdeck and Co-Pilot. So Cobdeck and Co-Pilot are performing better than Entoprite for endotracheal intubation and child during chest compression. So in conclusion, unfortunately, no one model appears uniformly superior to another. What you have to do, you have to use what is at your hand. However, if you have the opportunity to purchase or to get 2 types of video laryngoscopes, if you have such luxury, you have to choose to get one apple and one orange. One ability could be stylet video laryngoscope or channeled video laryngoscope, which would be helpful in a patient with limited mouth opening and limited cervical movement, and
انا ما
angulated
شفتوش غير دلوقتي بس ما كانش في اسئله
laryngoscope
اصلا.
for better visualization, particularly if you have a bleeding from airway, if you have vomits, if you have extreme difficulties, and so on. And finally, thank you very much for listening, and I hope you enjoyed this evening. Thanks so much.
Thank you, Dr. Tahan, for this interesting, informative, and updated lecture. Please, Dr. Saad, allow my camera.
Sure.
Now the floor is open for any questions for Dr. Tahan. We have one question, Dr. Tahan. I think you addressed, but the audience need more information. Dr. Isam asked about what do you prefer, or is air track is superior laryngoscope?
Can you start your camera, please, Prof.
I cannot conclude for this fact. There is a meta-analysis comparing channeled video laryngoscopes, but in adults, not in pediatrics. They found air track is better than others. However, for pediatrics and up to the current available information from literature, we cannot reach for this conclusion. Using of any channeled video laryngoscope, it could be helpful in a patient with a limited mouth opening and restricted neck movement. However, you have to put in your mind, you should be very skilled in what you are using, regardless of type.
Okay. Also, Dr. Hisham Saleh asked about, he found difficulty during passing the tube, although the view is very obvious and clear.
That is,
ask you how to overcome this problem.
Yes, that's what I explained during the talk. This is one of the major problems. You can insert the tip of the scope until the glottis to reach for the best glottic view. But in such case, you cannot advance your tube in natural care. You need to sacrifice with this. You have to get the tip of your laryngoscope, either channeled or traditional plate, as far away from the glottis, just to see part of the glottis in a good view, but not an optimum view. Then insert your tube, the natural curve, with a hockey stick stylet, reshaped stylet. It will advance the tube into the glottis. Of course, in channeled video laryngoscopes, we are very rare to use stylets. We don't need to use stylets, but you might need to use bougie in such case. Also, this might facilitate introducing the tube. You need to intubate with bougie, with the reshaped tip of the bougie to 30-degree or hockey stick appearance, to intubate with bougie, and then advance through the channel, the guided channel of the scope.
Thank you, Dr. Tahan. Thank you for this updated scientific talk. Thank you.
Sorry, I have a question, Dr. Tahan, about do you have experience with Barker tube, with flex tip siliconized tube?
Yes.
Just to prevent this issue?
Yes, to some extent. Yes, there is a problem in this one. You need to rotate the tube 180-degree counterclockwise to avoid hitting against the cord to introduce it.
Thank you.
Welcome.
Okay.
Dr. Tahan, I have a question, if you don't mind, from myself.
Sure.
Do you think that video laryngoscopy are going to be, especially in this time of COVID, are going to be a little bit more widespread, as we would like to improve the experience of the beginner or the trainees to use the, the normal conventional laryngoscope, and now are moving swiftly to video laryngoscopy to avoid direct contact with or potential contact with the COVID air droplet infection?
Dr. Saad, this is a very important question indeed, and I thank you for highlighting this. or guidelines released from BSA, from ASA, from ASA, from CRT, and also from EACTA itself. It is a recommendation, and Difficult Airway Society, of course, European Difficult Airway Society, all of them including the first and only choice to use a video laryngoscope as much as possible and accessible. Yes, it is a problem. I know it has a financial constraints. However, there are many introduced cheap video laryngoscopes coming. It is not a brand, but it is working well. It's coming from different areas, from China and India, and I think they are working well at an affordable price to some extent. Yes, I agree with you. It is a problem in training, and not all only during COVID area, but also before COVID era, because during this time we are afraid about our patients indeed. Okay, and we don't have such luxury to have simulation in advance. Yes, we are offering for them a half day or 1 day difficult airway workshops, but it is not enough. So we are using video laryngoscopes to avoid injury for our patients, particularly when we are talking about pediatric patients. They might affect their skills in using traditional blades and straight blades to gain the skills with straight blades, with curved blades, which sometimes the video laryngoscopes is not a common, and it is only my own experience, and very few number of cases you might gain experience and you get difficulty in using a video laryngoscope, and you have to go back for a straight blade sometimes. And here is the problem. But if we discuss this problem from other aspect, if we look for specialization in surgery, like special types of specialization in surgery itself, for specific type of surgery, for laparoscopy, for endoscopy, and so on, these surgeons also, they are lacking experts and experience and skills, and using general surgery for laparotomy, for exploration, and so on. It is the same problem. It is obvious it would happen with anesthesiologists in next generation.
Thank you.
Welcome.
Any other question from the floor, please? Very nice. And at the end, I would like to thank all eminent speakers tonight. The first time to use modular teaching today, pediatric anesthesia and neonatal anesthesia. I would like to thank always. The first one is Professor Samir Ansari. He's honored us by his presence today as a moderator of this session with Professor Manal El-Gohari. The three top speaker experienced anesthesia, pediatric anesthesia in the world, Professor Hani Zahabi, Professor Mu'taz Abdurrahman, Professor Muhammad Tahan. I can't thank you enough on behalf of my colleagues and on behalf of all attendees. Next Sunday, we are starting to just move the time a little bit forward at 7 o'clock Cairo time. Just to keep tuned, if we decide about that, we have to have voting with our professor and our colleagues, because the people in the Gulf area and the Far East are a bit late at the moment. We are in Dublin and England. We are okay. That's fine. We can stay longer, but they are, I think, they are around 11 before midnight there. Next Sunday, we will have Professor Samir Ansari again with a very nice, interesting case discussion in cardiac ICU. And Professor Magid Salah will have speak about advanced cardiac monitoring and cardiac anesthesia. And once again, we have our top speaker tonight, Professor Muhammad Tahan again, and he will speak to us about very, very interesting topic. We'll keep it in the advance in the advertisement. And everybody, thank you very much, and good night, and hopefully we'll see you again. That is one of the most successful sessions in the MEGA online course. And on behalf of my colleagues, I would like to thank you very much, and hopefully we'll see you again.
ساعدة بس تحط الفيديو عندي
Thank you.
سلام للناس إذا ممكن يعني if you don't mind. الفيديو عندي is the video is
oh, sorry. Dr. Mu'taz?
yeah.
Dr. Mu'taz? Sorry, Dr. Mu'taz, I haven't seen that. Yeah, your lecture was very interesting, interactive discussion. I'm so proud of you tonight. I'm so proud of myself that I am here between all of those eminent top people in the Department of Anesthesia. And thank you again. And hopefully we'll see you again next Sunday. Thank you.
Thank you very much all. Thank
so
you.
much.
Thank you.
Thank you.
Thank you, Brockman. Thank you.
Dr. Muhammad, Dr. Hani, everybody. Thank you very much.
Thank you. Thank you.